Hi everyone, my name is Molly Berman. I'm a clinical psychologist and assistant clinical professor of psychiatry at UCSD. I work in the adult cystic fibrosis program and with cancer patients at Moore's Cancer Center. I heard that there was a great patient panel this morning, which unfortunately I missed because I was in clinic. So someone will have to let me know afterward if some of this material resonates with what was spoken then. So our agenda for today, we're going to talk about why are we even discussing mental health with NTM, how does mental health affect the disease and its treatment, how to evaluate for key issues like depression and anxiety, and included in that some challenges in evaluation, how to refer for help, how to recognize urgent cases, what therapists can offer, and then we'll close out with some example interventions. Don't know why the slide is blank. So this is confusing. I'll have to wing this. Okay, thank you. Okay, so why are we discussing mental health with NTM? As you know, NTM is a chronic disease that requires long-term therapy, and as we've seen from the research, this can cause or amplify negative emotions for many patients. Today, I also want to say that I'm going to be speaking more about the research in CF and mental health because there's very little research on NTM and mental health. But as you know, because of the connection between the two diseases with the high treatment burden and what it's like to live with a chronic illness, there is a high overlap. And so hopefully we can see a useful model at looking at CF and mental health. So the largest international screening study performed in a chronic respiratory disease was published in 2014, and this was done with CF patients. And what they found is the high rates of depression and anxiety. Specifically, they found elevated symptoms of depression in 19% of adults with CF, elevations in anxiety in 32% of adults with CF, and overall elevations were 2 to 3 times those of community samples. So really high rates. As you can tell, depression and anxiety are some of these key issues, as well as the mental health challenges that go with medication adherence and quality of life. So how does mental health affect NTM and its treatment? Well, research has showed us that daily treatment burden is shown to exacerbate issues with adherence in patients with bronchiectasis with chronic Pseudomonas infections. And also when we look at CF, we can see that psychological symptoms have been associated with decreased lung function, lower body mass index, reduced treatment adherence, worse health-related quality of life, and more frequent hospitalizations and increased healthcare costs. So again, this is a really important topic, not only for the quality of life of the person, the patient, but also in terms of their health outcomes. Now that we know it's important, how do we evaluate for anxiety and depression? Going back to that article in 2014, the ICMH, the International Committee on Mental Health in CF, recommends screening annually using the PHQ-9 and the Gad Seven. I'm going to take a closer look at those screeners in just a moment. But just so that you know, before immediately treating the patient, when someone screens high on those measures, it's important to get a healthcare provider who has the training and expertise to see whether the elevated screening scores is actually clinically significant. It's also great to have someone in clinic who can be responsible to initiate and coordinate care and monitor the treatment effects. Otherwise, that patient might get lost in the system. And of course, it's really important to keep primary care physicians and mental health, if the person already comes in with a mental health provider, in the loop so that everyone can stay coordinated. I find this a helpful flow sheet. This is what that 2014 article recommends in terms of annual screening. And it's nice if we want to use this model for NTM, for example, it's a nice, helpful thing to just have up in clinic or to keep in mind that annual screening is very important. Here's a screenshot of the PHQ-9, which maybe many of in the room are familiar with. This is a screener for depression, and specifically it screens for major depressive disorder, and it's based off the criteria for major depressive disorder in the DSM, which is our diagnostic manual. So it asks questions like, have you been feeling down, depressed, or hopeless? Have you had changes in your appetite, like difficulty eating or overeating? Have you had trouble sleeping? Number 9 is an important question because it screens for suicidal ideation. And we're going to talk more about this later, but the important thing to know is if someone answers yes to this question, we need immediate attention, that someone will have to do an immediate evaluation and see if that patient needs help. The Gad 7 is an anxiety screener, and it's based on the DSM's criteria for generalized anxiety disorder. So it includes questions like, do you have trouble relaxing? Do you have worries that you can't control? And as you can see, the cutoff numbers are also listed on the screen. Some important considerations when screening are, first, as I've just discussed, that these screeners are based off of DSM criteria on a community sample. So they're not made for people with chronic illness. And for example, in CF, what we see is people have difficulty eating. That doesn't mean that it's necessarily due to depression, but they're going to answer yes, most likely on that item. And that's why it's really important and why it's great that there have been more efforts to look more at specific disease-specific tools. And in fact, I was happy to see in 2016 there were some patient-centered research priorities published, and Dr. Winthrop and Olivier, who I think are in the audience today, are part of that team to really look at the importance of quality of life in NTM and bronchiectasis patients. Dr. Quittner has also really been big in the world of both CF and NTM and bronchiectasis, and she and her colleagues have come up with specific assessment tools for CF, for bronchiectasis, and now for NTM too. And those NTM symptoms that they measure include loss of appetite, feverishness or chills, bad taste in the mouth, and problems with memory. And the benefits of using these modules are that you can use them separately as an entity of themselves, or you can use them in conjunction with the PHQ-9 and Gad 7. They've also found that fatigue can be particularly overwhelming for NTM patients, but intermittent, and patients report fatigue as one of the biggest impacts on quality of life. So again, it's great that we're looking at more specific interventions or ways to measure fatigue and some of these other criteria. Another important thing to mention is that screening tools are based on self-report, and the patients might not recognize how well or how poorly they're doing. So in CF clinic, we often see patients might mark 0 for every item on the PHQ-9 and Gad 7, but might actually have some symptoms of depression or anxiety. Or similar, we have some patients who mark high scores every time, regardless if they have had some decreases in some of the symptoms. So that's why, again, it's really important to have someone on staff, like a licensed clinical social worker or a therapist, a psychologist, to follow up and see how that patient is doing clinically. Now that we know that how to screen and how to do this, what do we do if we get someone who screens positive? Well, that 2014 article recommends that for someone who screens positive for mild depression or anxiety based on those screeners, we should provide education about depression and anxiety, give preventative or supportive interventions, and then, of course, re-screen at the patient's next clinic visit. For moderate depression or anxiety, we should give a referral so that that person can get evidence-based psychological interventions, and the ICMH recommends specifically CBT or IPT, which I'll discuss a little later. And they also say if the therapy is unavailable, if the patient declines, or it's not fully effective, we should also consider medications. For those who screen positive for severe depression, using both evidence-based psychological interventions and medications is recommended. For someone with severe anxiety, they recommend exposure-based CBT, which is a type of CBT that exposes the patient to the feared stimuli in a safe environment so that we can break that pattern of avoidance and fear. And similar to depression, if the CBT is declined or unavailable or ineffective, then we should take a look at medications. And what they recommend is first-line SSRIs or escitalopram, sertraline, or fluoxetine. And they say that lorazepam can be considered for short-term use for moderate to severe symptoms with medical procedures. And so that's similar to a community sample where we wouldn't recommend benzodiazepines long-term, but if we can use them for a short-term intervention, they can be really helpful. Here's the article's flow sheet in terms of what we do with the screening scores, and I find this very helpful, and it's a go-to thing that we use in our clinic in terms of what we do when the person is screened positive. So the next question is, how do we find referrals? What do we do when someone screens positive and we want to get them help? First, social work, if you have a social worker available in your clinic, is an excellent resource. They know a lot about insurance. They usually know a lot about community providers, so really use them. I often recommend, if I don't have a social worker there, or if I'm not sure where to refer the person, have them call their insurance for a list of covered mental health providers. It's an easy way to make sure that they're not going to have to pay out of pocket. And patients can also go back to their primary care physician and get mental health through that. Usually their PCP goes through insurance as well and knows some people in mind, so that can be helpful. Finally, it's really helpful to get a list of providers in the area who have experience with chronic illness or behavioral medicine, just as a go-to list to give people when you need it. And an important point overall is that physicians are often the gatekeepers for mental health treatment. And what I mean by that is that when someone screens positive and we say, call your insurance, you need help, if they leave the clinic and see that number or are told to call their insurance, they likely might not follow up unless they really feel that the physician thinks it's in their best interest. So physicians spend time to really say why this is important, how they're concerned about the patient's mental health. That can go a long way in terms of helping them follow up. Another important thing is to really destigmatize and normalize what the person is going through. Often when I meet patients, the first thing they say to me is, am I crazy? Is that why you're here? And one of the things that I say is, no, you're not. And actually, this is a very, very normal and typical response that we see to the stress that you're under, that it would be abnormal to not see a reaction to having just the daily treatment burden that you face or the chronic illness. And so sometimes I even cite the research that this depression and anxiety are very high. And just to help them, our job is not to pathologize, of course, but to help them feel comfortable so that they can get that additional help. In terms of recognizing urgent cases, the PHQ-9, number 9, was that question that I mentioned before, which screens for suicidal ideation. Specifically, it asks, are you having thoughts that you would be better off dead or having thoughts of wanting to hurt yourself? If someone answers yes to that question, the important thing is they might not necessarily be actively suicidal. And what I mean by that, we differentiate between active SI and passive SI, and that sometimes people with chronic illness commonly have passive SI. They'll think, for example, with CF, I'm tired of dealing with this pain, I'm tired of dealing with these treatments, I would rather give up, or I'd rather not be alive because of this. That doesn't necessarily mean that they have a plan or intent to go out and harm themselves. So that's where assessing intent and plan is really crucial. If, of course, they do have an intent and plan, we need to send them to the emergency room or get security or 911 involved right away to keep them safe. And with passive SI, we don't need to ignore it or dismiss it. It's very important, of course, to keep track of it. But many of my patients with chronic illness experience passive SI frequently, and so we want to be there to support them, but not necessarily refer them right away. Also, knowing the patient's psychiatric history is important. Have they had episodes of mania or depression in the past? That's going to really cue us into whether they might be more likely to have future or current episodes. Also, asking and assessing their current stressors that might be related or unrelated to their disease. So, for example, have they moved recently, a change in jobs, a death in the family? All of these can affect the patient's mental health and bring out symptoms of depression or anxiety. Included in that, too, is also recent exacerbations in their treatment. So often with CF, if they're struggling with their lung functions, they might have more passive SI or might have more symptoms of depression. So it's really good to keep that in mind. Also, the great thing about physicians is when you work with someone over time, you can see their baseline and start to recognize when there's a difference in the patient's usual presentation. So you might notice that they might be more jittery or they're crying much more tearful than they normally are in clinic. And that's really helpful. As a therapist, I often don't get to see their baseline or know what they're like. And so if you think that something's up, then it probably is. And do a further assessment, figure out what's going on. The other great thing as a physician is that you likely have that long-term relationship and the trust built with the person. So they might be more likely and probably are more likely to disclose to you if they're having difficulties than a first-time therapist who's popping in to meet them. So what can we do? What happens after you refer someone to a psychologist or a therapist? As you can see on the slide, there are a range of interventions, and I've included the ones that I use specifically with patients with chronic illness. I'm going to go through each of these, and at the bottom, I just want to mention that there are also brief interventions related to difficulty sleeping or medication noncompliance or stress reduction. So these would be one-time interventions, for example, that we might be able to provide the person in the moment that can still be very effective. They just might not be a referral to outside treatment. Cognitive behavioral therapy is the most common therapy to see, usually from psychologists working in a health setting. Many of you in the room might be familiar with this, and what it does is it focuses on the relationship between our thoughts, our mood, and behavior, and that triangle, that image on the board, is something that I introduce very early on to my patients so that they understand the process that we're going to use. And what it does is we help rework cognitive thoughts, so changing unhelpful thinking patterns, as well as use behavior modification. CBT really focuses on the here and now and solving the patient's current problems instead of delving into the past. I'm going to talk a little bit more about CBT because it is such a helpful intervention and can likely be very useful for NTM and bronchiectasis. So for a treatment plan for depression, what we normally do is start out with psychoeducation on the cycle of depression. So again, going back to that triangle, but using it specifically for depression and how that patient's life fits into it. We also have them do mood monitoring, which is literally giving them a worksheet that has them rate their mood on a scale of 0 to 10 every hour of the day, as well as what they're doing during that day and during that hour, so that they can begin to see what is helping my mood, what's worsening my mood. Behavioral activation is another important component, which often sounds easier than it is. It's really getting that person to get up and get moving again, because depression can make the person retreat. So getting them to walk to their mailbox, getting them to start socializing or calling friends. Cognitive restructuring helps take a look at those negative automatic thoughts that the person might have. It helps them either to challenge the thoughts, to weigh the truth or the evidence of the thought, and then come up with more balanced cognitions. Assertiveness training is something that we use to help the person voice their needs or their concerns to loved ones, to family members, even to physicians. And so it might even involve some role plays with the therapist. For anxiety, and this could be anxiety with or without panic attacks, we first start, similar to depression, with psychoeducation on anxiety, on stress, and on fight or flight system. We'd also teach diaphragmatic breathing, so we'd practice that with the person in session. We'd also use other relaxation training techniques and might use exposure therapy, which is something I mentioned earlier. And similar to depression, we'd want to look at the cognitive restructuring and replace and restructure cognitive distortions that are focused on their anxiety. Problem-solving therapy is a very closely related therapy to CBT, and the main tenet of it is that we don't, as a therapist, want to solve the person's problems for themselves, but help them to learn how to solve the problem so that they can then take a proactive role in their life and before problems come, really help to break them down. Interpersonal therapy, which was recommended by the ICMH for depression, focuses more explicitly on the therapeutic relationship and using that therapeutic alliance and the empathy in it to help the person change their behaviors, to structure successful experience, and to regulate their mood. Acceptance and commitment therapy, otherwise known as ACT, is a third wave mindfulness-based therapy. I find it particularly helpful for patients with chronic illness, because oftentimes CBT can rub up against what's going on with the chronic illness. So for example, with a cancer patient, they might have the thought, I'm going to have a cancer recurrence. And we can never tell them, of course, that that's not true. We can't totally dismiss that thought because we can never give them that. So with ACT, what it does is it more explicitly says those thoughts might be there, but we focus on meditation and mindfulness. So the thoughts might be there, but we don't have to latch on to them. And how do we still follow a values-based life and not let those thoughts get in the way of what we're doing? So it uses more acceptance and mindfulness strategies to increase psychological flexibility. Motivational interviewing is something I imagine many physicians are familiar with, and this focuses on behavior change and getting that patient's intrinsic motivation to change their behavior. So it really tackles ambivalence. Grief or bereavement therapy, we tend to think about more in the context of when someone has lost a loved one, but I find it to be very helpful for chronic illness, especially when a person is first diagnosed and the loss of functioning that's associated with that, as well as throughout their treatment trajectory, can be a very helpful model. This is an example handout that we would use for CBT with depression. And as you can see, it's called GRAPES, and that stands for being gentle with yourself, relaxation, accomplishment, pleasure, exercise, and socialize. As healthy adults, often we do all of these activities without even thinking about it. We probably have done these all on a day-to-day basis. What happens when someone's more susceptible to stress, to anxiety, to depression, or has a chronic illness is that aspects of the GRAPES might be left off. So we really want to highlight that and get the person to be more mindful and pay attention to what they're doing and start to integrate those activities back in their life. It's also really important to emphasize with the person to start small, that we don't have to set big goals. So socialize might mean texting a friend. Exercise might mean walking to your mailbox. Those are great. We don't necessarily even need to introduce new activities. We're thinking about starting new habits, because this can take a few months to get the person back to fully doing these without even thinking about it. In terms of anxiety, a helpful intervention to use as a one-time thing can be giving them mindfulness apps. There are a lot of terrific apps out there. Two of them that I mentioned on the board are Headspace and Insight Timer. And the beauty of using these is that they have a lot of education built into them. So once the person starts to use them, they're going to learn how to do mindfulness or meditation things on their own. And that concludes my talk for today. There's my contact information, citations. Thank you.